So I'm going to be talking this morning about an introduction to autism. This is only an introduction. We're going to hit it very lightly, but I'm delighted to be here to talk, and we'll have a chance, as I mentioned, for this group to have questions later. I should just mention my conflicts of interest, which are a grant of which Kasia is the principal investigator, along with a number of books, and I also edit the Journal of Autism. This book in particular, I would mention, whoops, and I lost that book because I did something to the page. Oh my gosh. Oh. Please don't start on me. Slideshow, back to the current slide. That's what I get for messing with the thing. I'm not going to touch it anymore. The book in the top corner on the right is a third edition of a book that originally got started for my undergraduate class from Cambridge University Press, and it's just come out in a third edition, and it's relatively inexpensive. So I want to talk a little bit about autism in terms of as a diagnostic concept, a little bit of an overview of the field, and something about diagnosis, and then move on to key findings from research, and then talk about outcomes in treatment, and finally, our current needs and some social policy issues, which is a fascinating area. So, development of the field. The origins of this really antedate both Kanner and Asperger. If you look, starting with the work of Itard in France at the end of the 17th century, early 18th century, his reports on Victor, the wild boy, interest in so-called feral children who presumably were being reared by animals. Most of those children probably had autism. If you read the reports of Victor, he had no language, he had a lot of unusual behaviors. He probably either eloped from his parents or was abandoned and then showed up in Itard. That people assumed this romantic notion of animals taking care of children if they were found in the wild, which I can tell you would not happen. They would be food. In point of fact, with the possible exception of dogs, animals are not to treat children like animals. But it's interesting that we probably can see the first reports of children with autism at that point. Then if in the 1800s, and the book on the top corner here, in a different key, is a wonderful history of autism. These people tracked down Connor's first patient, Donald, who was still alive at that point. May still be, he's in his 80s if so. And they tracked him down and talked to him, but they also pointed out that in the 1800s, some of the institutions in Massachusetts that took children with what we now would think of as intellectual disability, mental retardation, many of the cases described were cases where it sounds like the child had autism. From the point of view, however, of actually defining autism and first describing it, credit goes to Leo Kanner, the first American child psychiatrist, a refugee from Germany. He was at Hopkins, and he talked about 11 cases of children who had two things. One was autism, living in their own world, not being socially connected. And the other thing was what he called resistance to change, and we'll talk more about that. Resistance to change actually meant several things. It meant literal trouble with change. Having trouble, had to take the same route every day to go to the Big Y or Stop and Shop. Any deviation, the kid fell apart. Same thing for changing around the furniture in the room. Connor mentioned some of his patients, as they would come back, would be upset with him because he had changed how his office was arranged. But this insistence on sameness also meant a tendency for the child to use routines, and Kanner actually, as part of that same package, included some of the unusual behaviors and mannerisms, the stereotyped body movements, the hand flapping. He saw that as an attempt on the child's part to maintain sameness in the environment. So the interesting thing here is he's talking about this interesting paradox. On the one hand, these are children who are not socially clued in, but they're hyper clued into the non-social environment. And we're going to try to understand more about that as we talk today. A year later, Hans Asperger, who was a medical student in Vienna, and he was during the war, he was in Austria, in Nazi-occupied Austria, and he talked about a group of boys who had something he called autistic personality disorder. And again, it's been translated various ways from the German. That's probably the best way to translate it. These were boys who had self-centered qualities, but these didn't show up until the kids entered preschool, when they would hug inappropriately other kids who didn't know who they were. These were boys who had unusual interests. They often pursued their interests with great intensity to the point where it interfered with their learning of other things, which is a key point, because it's that interference with learning that moves it into being a disorder. And he also pointed out that the families had their family life revolved around the child's special interest. A kid who's interested in trains, they'd have to go to the train station to see did the 6:15 from Leipzig get in on time. And so he talked about these kids, again, having autistic personality problems. He did not see this as a developmental disorder. Effectively, these two descriptions set the stage for what's a continuing debate. the tension between the broad view and the narrow view. The broad view, as we'll talk about, is supported somewhat by the genetics, which has identified many genes, potentially many gene variants, which means there's probably a lot of other combinations of genes out there where people are maybe a little strange or a little hyper-focused, but they don't have autism. In contrast, the narrow view, the Connor view, is of classic childhood autism. And this is the tension that continues today, and we'll talk a little bit about it with DSM. So the big accomplishments, in the 1950s and 60s, quite frankly, not much happened. Things started to happen in the 70s as children with autism were followed. In the 50s and 60s, as we'll talk about with the DSM, these were children who were regarded as having childhood schizophrenia. And that was because that word autism. People thought, oh, autism, we know that word is one of the 4 A's that Bleuler used to describe schizophrenia. He talked about self-centered thinking. That's not what was being talked about here. These were children who came into the world without a predisposition to connect with people. But that was a term that was used. It was very much impossible to sort all this out because the childhood schizophrenia, which turns out to be extremely rare, but people really had no good ideas. One of the sad things, unfortunately, was people in the 50s and 60s, as we'll talk about, started blaming the parents for the child's problem. And we'll talk about the history of this, which is very interesting. In the 1970s, however, several things happened. One was an awareness as children were followed over time, they had a very high risk for seizures. About 20% of children with classic autism will develop seizures of various kinds, usually major motor grand mal seizures, but at various points in development, early childhood and also adolescence, which otherwise is an extremely rare time for people to first develop seizures. The other thing was in the late 70s, the first twin study came out. There had been a paper a few months before that basically by 2 prominent geneticists that said there's no genetics to autism. And then the first twin study came out, which said there's tremendous genetics. The first twin study was done in the United Kingdom, Susan Folstein and Michael Rudder. They looked at same-sex fraternal twin pairs, and the reason they looked at same-sex is there's a gender issue bias in autism, and then identical twin pairs. And they discovered among the identical twins, it was amazing, highly concordant. So if you had an identical twin with autism, you were very, very likely to have autism. Not so among the fraternal twins. And their first study, which is pretty small, the risk was about the same as in the population. We actually know that now it's actually somewhat higher. There was an increased risk for fraternal twins, but not nearly as much as identical twins. And finally, in the 1970s, the first studies came out that showed structured education and behavioral approaches were more effective than unstructured psychotherapy, which until that time had been the only treatment. Let me say a word or two about DSM. DSM 1 and 2 are largely of historical interest. They're very theoretically based. They have their own biases. Part of the problem with having a theoretically based diagnostic system is if you don't mind the theory, you're kind of screwed. And that's a problem. And so the big change in DSM 3, which I give Bob Spitzer, whose picture is here on the side, great credit for. Bob Spitzer, who was part of the Washington University School in St. Louis and moved to Columbia, and they were very, very focused on developing what they called research diagnostic criteria. This was a real change in psychiatry. When DSM-3 came out, it really revolutionized the field. In DSM-3, autism was included for the first time. It was called infantile autism. It was grouped under a class of disorders called pervasive developmental disorders. They came up with this term out of nowhere because it had no history. And in retrospect, they could have used a better term, autism and related conditions, but they didn't. They used this funny term, pervasive developmental disorder, but autism was included. The trouble with their first definition was it very much was a definition of infantile autism. It was monothetic, which means you had to meet all the criteria, pervasive lack of responsiveness. We know that as children get older with autism, they do respond. They do develop some social skills, especially if they have intervention. Now, often those are odd, blah, 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 but it's not pervasive. So there was a funny category in DSM called residual infantile autism, which was very problematic because the residual problems weren't so residual when you met these kids and adolescents and adults. So many major changes were made in the next iteration, DSM-3R, which came out fairly quickly. We moved from infantile autism to autistic disorder, and now all of a sudden we have the polythetic description of the diagnostic criteria, some from A, some from B, some from C. Social communication and resistance to change. And this was, again, a big change because all of a sudden you can have different combinations that could get you a diagnosis of autistic disorder. It was much better in terms of approaching the whole range of the syndrome, probably overdiagnosed among the more severely intellectually disabled. Then we had DSM-4. This was done in conjunction with ICD-10. ICD-10 is the world system of diagnosis. Technically speaking, DSM is regarded as a regional variant, I believe. And of course, DSM has captured the field and did back in 1980. So around the world, that's what people used. But ICD, the International Classification of Diseases, which is based in Geneva, as part of the World Health Organization, by treaty, we're obligated to have a connection with ICD. And that means those funny codes when you go to the hospital, you have pneumonia, there's a code that's an ICD code. And so DSM is related to ICD around these codes. But for doing the DSM and the ICD, at the time that we were involved in doing it, and I was in charge of the DSM part of it, and Mike Rutter was doing the ICD-10 part of it, and we agreed, this is crazy. We don't need to have two diagnostic systems, one for America and one for the rest of the world. We need one system if we can possibly do it. This had all kinds of complications and other issues, which I won't get into. But anyway, in the end, we did a lot of bells and whistles, and we did a big field trial. Over 100 raters, nearly 1,000 cases, 20-some sites around the world over a year. And we came up with a new definition that was essentially the same for DSM-4 and ICD-10. This was around for almost 20 years. And it worked extremely well. And as you'll see when I'll show you some of the research data in terms of research papers, there was just an explosion of research. Now let me say a word about DSM-5. And you can sort of get my take on it up at the top. Unfortunately, I'm sorry to say, DSM-5 was well motivated. I was early on, I was part of the process, and I, along with some other people, resigned because we didn't like the way it was going. They included a new category, autism spectrum disorder, great in terms of the name change. Another new disorder called social communication disorder, which had basically no or very little rational basis, but it was sort of thrown in there, I think, because they were rightly worried about not including some children. There were no longer sub-threshold categories, what we called in the past PDD and OS, or atypical autism. That's all gone. So the criteria, we had two rather than three categories: social communication and resistance to change. And this was done on the basis of looking at a big body of data from the ADOS and the ADI, doing factor analyses and other kinds of things. And the trouble with factor analyses, and I can tell you this from looking at the DSM-4 data, you can come up, I can tell you with the DSM-4 data, you could have a 2-factor solution, a 3-factor solution, or a 5-factor solution. You take your pick, depending on which you feel like works best. Again, I don't want to oversimplify it, but it is kind of you take your pick. And we went with the 3-factor in DSM-4 because we thought it gave us more flexibility. And they went with two factors basically in DSM-5, social communication, resistance to change. We reduced our number of criteria. We had a number of criteria in DSM-4 that I think over 2,000 combinations and permutations could get you a diagnosis of autistic disorder in DSM-4. So it was, whatever else was true, there were a lot of ways to get in. All of a sudden, we went from 2,000 to 12. And in some funny way, that's all you need to know in terms of what the issues are with DSM-5. So there's some good news. The good news is the recognition of the disorder. That's great. The bad and unexpected news, perhaps, is that despite the name change to autism spectrum disorder, the concept is more narrowly defined. And there's now been a series of papers. I'm going to show you one, but there have been a couple of meta-analyses that now show this. My colleague Jamie McPartland here and I and Brian Rykow, who was then here and is now an associate professor down in Florida, looked at the old DSM-4 data, what we could find. About 30 cases have been lost in a flood. Let me warn you about winter around here. But we were able to recode these data, and we went back and looked at them, and then we reprogrammed it in for DSM-5, and we discovered a very interesting thing. It was very specific, but the trouble was who it left out. And here's what happened to the cases. And what you can see here is among the high-functioning people with autism by clinical diagnosis, a fair number, almost 50%, lost their label. But look at Asperger's and PDOS. Most of them lose their label. This was not happy news. This came out, this literally was featured on the front page of the New York Times. And of course, what's the problem in this country? You lose your label, what do you lose? Services. And so this was not happy news. So by this time, the DSM folks had more or less wrapped it up. And they had to add a new criteria, which was, if you already have a well-established diagnosis of autism, Asperger's, PDOS, you can keep it. So that was the solution, which is back to my train wreck business. It's like we've got two trains running on the same track. And it's problematic, and I'm sure this will be addressed in DSM 5.1, whenever it shows up. Let me say a little bit about research and what we know. Genetics, we know there's tremendous genetic factors in autism. I'm going to say something about the social brain and interventions, and a little bit to show you that we think actually our interventions are producing better outcomes. Research has increased in terms of just literally the number of papers and the number of journals. I think there are over 20 journals now that have autism in the title. I'm the editor of the Journal of Autism and Developmental Disorders, which is the first one. When I first took over, now about 10 years ago, we had about 300 papers come in every year for review. I think last year we had close to 1,500 papers, which is just a tremendous number. And you can imagine, I've gone from having me and 2 associate editors to me and about a zillion associate editors. But let me say a little bit about this. Shows you the research early on, and this is grouped by 5-year blocks, except for that first block. So you can see that by 1990 to 95, we had over 5 years about 1,200 papers. So that's a little over 1,200 divided by 5, right? Not so bad. You can keep up with that. But look at what's happened more recently. I don't have the 18 data yet. It takes a little while to get them. But you can see they were close to 4,000 papers a year. So how are you going to keep up? It's good news and it's bad news because it's a problem in terms of just being able to master the literature. Why has research increased? Well, there's several reasons. First of all, there's a lot of basic fundamental interest in autism because it's a prototypical example of a disorder involving the social brain. There's a whole body of work on this. I'm going to show you a little bit. Brothers was the first one to talk about the social brain and really talked a lot about autism, and you're going to hear a lot here at the Child Study Center about social neuroscience. And it seems also to be very interesting because we can potentially bring the brain and genes and behavior together and understand more about fundamentally what makes us as people social. What makes us so social? There's also social political reasons. Parent groups and foundations have just tremendously increased in terms of number and their levels of support for research, which is fantastic. Autism Speaks, the Autism Science Foundation, the Simons Foundation, which is probably funding more research than the federal government is at the moment. But it's just really a tribute to the fact that parents who used to be afraid of talking about having a child with autism, they said, no, we're going to work on this. We're going to fix it. We're going to tackle it, which is fantastic. Finally, there's financial reasons, and people know Willie Sutton. Do people know who Willie Sutton was? There's a famous law in medicine called Sutton's Law, Sutton's Rule. Willie Sutton was a bank robber. And Willie Sutton, whose picture is here, they once asked Willie why he robbed banks. He said, because that's where the money is. Well, so the interesting thing here is as money has increased in terms of research, of course, people are on it. People who had previously no interest, all of a sudden they have an interest in autism. And I'll talk a little bit about the internet. It's got good news and bad news, but there's no question. There's more media attention. I just saw something on Good Morning America last week, which was a great ad for some lovely place that also talked about some slightly unusual treatments. But for good news and bad news, we've got the interest in this, and the internet we'll talk about. So understanding autism. What is autism? And this movie did a lot to get people in this country aware of autism, Rain Man. Autism is first and foremost a disorder of social interaction, including unusual patterns of learning and over-engagement with the non-social world. So, what happens if you have a social frame? If you come into the world and you're ready to play the social game, right? What happens? You pay attention to people. You pay attention to their faces especially. You pay attention to what they're looking at. You learn from just watching what they're looking at. If something is dangerous or safe, you look to your mom or dad. Is it dangerous or safe? You pay attention to their language. We were just talking about language learning. Language becomes very interesting early on. Kids with autism, all kids produce a range of sounds, some of which are not going to be in their language that they speak, but they lose those sounds because they don't hear them. Kids with autism sometimes have persisting, very unusual sounds that never would otherwise be used, for example, in the English language. They develop prosody. Before 9-12 months, they're sing-song back and forth. It's English prosody. They would prefer English prosody if they're growing up in an English-speaking household. So it's a whole very interesting package of stuff. And we don't send children to language school. That's one of the major proofs, as I was talking with some of my colleagues earlier, of the existence of God. that children really do learn language on their own, and they're very, very good at it. So even before the child is saying their first words, they're having these proto-conversations with their parents that are having about the same turn length. They're going back and forth. There's an expectation of this is my turn, this is your turn. This doesn't happen in autism, but this happens if you have a social frame. I can remember my first child who just had our first grandchild, and when she was born, she was 2 weeks late. It was a long labor and delivery. And my wife ended up having a C-section, and she spiked a temperature, and because she was a pediatrician, there's a zillion docs in the room, and so she has her C-section. I check that she's okay, and then I go off to newborn special care to see my new daughter, who's just been delivered, and walk in, and I said, can I hold my daughter? And of course, there's this big baby surrounded by all these tiny babies, and I hold her, and she's looking at me, and I'm looking at her, and we're off and running, and still are. And it's really amazing to see this happen. So let me ask you a couple of questions. What's more interesting, this or this? I would argue that you can't pull yourself away from looking at the faces. And part of the reason for that is we have a tendency as humans to seek the face. So look at all these pictures. I think you see a face in all of them, right? And none of these are human people. These are houses, these are bowling balls, eggplants. But isn't it interesting? And so I say in some funny way that for people with autism, children with autism, it's sort of like looking at this picture. How many Navy SEALs are hidden in this picture? Take a look and then make a guess, and I'll show you. A ton. But think of what if you came into the world and you couldn't make out people from the surround. That's going to cause some troubles. So if you put it another way, if you come into the world with a social frame, people are the center of your world. You're learning from them all the time. You're focused on them all the time. You have something called joint attention. Your mom looks at something, you look at something. You follow what they're looking at. You have incidental learning. You have the development of affect and emotions, and you'll help to regulate how you interact with your parents and back and forth. You also have a strong desire to communicate because it's so efficient in getting your message across. And people are the most important things in the world. So again, in autism, it's different. And we want to know a little bit about what we can understand about social development early on, especially in relation to the brain, but how this affects children with autism and their interaction. So let me show you very quickly. Again, in typical development, there's a very strong attraction to face from birth. We're able to see very, very clearly markers of this. Jamie McPartland, who's on the faculty here, his first seminal work was on looking at faces and discovering a very characteristic EEG phenomenon and looking at faces, which I'll show you in 1 second. And here we go. Here's Jamie and a baby, and here's someone doing the EEG, these are much easier to do these days than when I first got into the field. You just whip the hair and put on this little funny cap. You're off and running. But the interesting thing, as Jamie has pointed out, is this. When you average many of these things for looking at faces, kids with autism, kids without autism, you find this. And this is called the N170 because it's negative and it's 170 milliseconds out. For people looking at faces, there's a very characteristic response. And it's specific to faces. But look at the people with autism. It's slower and it's not the same. So how can we understand this? This is a study Bob Schultz and a group of us did some years ago, looking at faces versus objects. Happily, this has been replicated many, many times now. We showed people lying in the MRI machine, so it's magnetic, no radiation. One button for same, one button for different, same or different, same or different, same or different, same or different. Faces and objects. And the idea is we're going to compare and contrast where does the blood flow go for objects versus faces. And again, what we see is for the typical folks, there's an area called the Fusiform gyrus, which is right about here, or most of us right under the ears, on the bottom side of the face, that is a specialized face recognition area. For people who are typical, that lights up, we get more blood flowing there, but not so for the people with autism and Asperger's. And again, these were high-functioning people. Interestingly enough, we had one of our students, one of our trainees, we had one child who had a very strong interest in something called Pokemon. For Pokemon, that area would light up. And the Pokemon was in contrast to faces, including family member faces. So again, it's not that that area didn't work, it didn't work for the faces, which tells us there's something different about the wiring. which is another very interesting thing. This was a Yale undergraduate project from one of my students in one of my classes who came to me and said he wanted to do this study on eye tracking, and I said, well, I don't know. I'd seen an eye tracking set up in the Netherlands, and you had to put the person's head in a vice, and you had to paste things around them. I thought, oh my, this is never going to work for a person with autism. He said, no, the technology's gotten much better, and Ami Klen, who was then here, and I managed to raise a little money to help him build this $20,000 baseball cap. And at that point, eye tracking had not been done in autism at all. It had been done a little bit in children for looking at eye movements in reading problems and dyslexia. It had been done in schizophrenia, looking again at eye movements, but nystagmus, but not so much in looking at what the person was looking at. And so we looked at this for the first time. We took some little 5-second clips, very short clips from a very intense movie that involved really only 4 people. It was black and white because we, at that point, didn't know what color was going to do to it. And this is a nice movie about a pleasant dinner party among 2 couples, faculty at a New England college, called Who's Afraid of Virginia Woolf? And for those of you who have not seen this is a very intense movie. And these people just tear each other up, right? It's like a Greek tragedy. But the interesting thing is we show little clips from this movie. And here you can see the lovely Emily Volkmar demonstrating for $10, which she negotiated up from $5. And she's watching this. She's got a very tiny little camera on her hat. One camera's pointing that way, one camera's pointing this way. It's infrared, so she can't see it. But we can actually track, based on what her retina is looking at, the most sensitive part of the retina, what's she really focusing on in this scene. And I'm going to show you data from our first 2 people, a man with autism who's independent and self-sufficient, but who very much has autism, and a typical viewer who's not quite as bright. And here we go. This is about 5 seconds of the movie condensed onto a single frame, okay? At the top, you see the typical viewer, back and forth to the eyes, and the bottom, you see the person with autism, back and forth to the mouth. The interesting thing, very quickly, as a total aside, when my daughter is doing this, we were doing this for a German television crew, and the guys, so she did it because they showed up and said, we want a child. I said, I can't get you a child, I'll see if my daughter will do it. And they said, oh, fine, this is wonderful, wonderful, wonderful. Now show us you had autism. And she said, Dad, what am I supposed to do? At this point, we were very early on this. I said, sweetie, look at the objects. And so she immediately looks. And at this point, keep in mind, I have seen this movie 100 times to pick out the clips. What does she find in this movie that I'd never seen? See in the top corner? There's a map of Martha's Vineyard, which I'm going to tomorrow. She'd been going there all her life. I've been going since 1980. I had never seen that map because, of course, I'm looking at these people who are tearing each other up. And the interesting thing, here's a scene in the movie, something scary has happened. It looks like the husband's coming out to shoot his wife. He's got a gun, out pops an umbrella, ha ha ha. Big joke on everyone, but the couple doesn't know that yet. But you see where the typical viewer goes? Straight to the eyes. And the person with autism goes straight to the mouth. The trouble with this is, if you're sort of an eye person versus a mouth person, the eye folks get about 90% of the social affective information. The mouth is much less. This actually has held up pretty well in meta-analyses. The eye business, especially the mouth business, is a little more variable, but I think that's probably more methodological than anything. But in our first series of cases, so this is now a larger series of cases, you can see here there's no overlap in terms of looking at the eyes. There's something called Cohen's d, which is an estimate of the strength, the effect size. The Cohen's d here is 3 point something. It's a whopping effect. You know, usually in treatment studies, we get a 0.7, 0.8, we think, oh, this is great. But this is what we're against in terms of the treatment, is the severity of this social problem. So what does all this mean in terms of outcome? Well, the interesting thing is, as we've gotten more aware of what the needs are and the special intervention challenges, but also the needs for structured teaching, we've gotten more effective programs. Increased awareness has also led to earlier diagnosis. You're going to hear from Kasha. We're very interested in autism in very young children. And we think there's probably now a better outcome as children have gotten earlier and earlier interventions. I'm going to show you some data on that. And we're interested because we think here especially, we want to integrate clinical work with research. Now let me point out there's some issues in terms of outcome. The earliest studies keep people confused with schizophrenia. That was a problem. More recently, there have been some changes in the criteria. One of the big things that happened in this country was Public Law 94-142 back in 1974, 75, I think. IDEA. The law said any child with special needs who walks through the door is entitled to a free and appropriate education. This was a big game changer. Autism was specifically mentioned. All of a sudden, schools had to provide services. Before this time, parents could be told by the school, we can't educate this child. Go put them in one of those nice training schools, which is what happened. And so kids went to institutions, they learned at institutions, but they didn't get interventions of the kind that we know are effective. And so this all started to change with Public Law 94-142. There's all kinds of issues in terms of the methodology and the outcome, and if anybody's interested, we can talk about this if we have time for questions. But I'm going to sample some data, and I warn you, anytime somebody warns you, pay attention. I'm cherry picking data. I'm cherry picking for a good reason. I'll tell you why in a second. But these are data from Pat Hallen and Elena Maginati's review in 2019 in that book I mentioned to you from Cambridge University Press. Good outcome means you're out there. You're on your own. You're self-sufficient. Fair outcome means you have some reliance on other people, usually your parents, but you're checking in with people, so it's semi-independent. And poor outcome is you're totally dependent. And we'll have a chance to talk about the really good outcomes because we do have some kids who have amazingly good outcomes. And these are the first outcome studies, and the reason I cherry picked these, I'm going from 56 to 74, and why do I stop at 74? Because Public Law 94-142 kicks in. So this is the first set of studies, there's no mandates, people are doing the best job they can, blah, 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 but nobody really knows what they're doing. But look at the number of good outcomes, maybe averaging 5%, okay? And poor outcome is probably about 2/3 of cases. Now we're going to skip ahead, and we're skipping ahead. We're jumping 15 years to let Public Law 94-142 kick in. And I'm going from 89 to 2003. I stop at 2003 because 2004, we had DSM-4. We include Asperger's. That's going to make things look better anyway. So that's the reason for this sort of cherry picking. But look at what's happened with the data. The number of good outcome, we're talking 20, 25%. And that's because we're getting more and better interventions. And there's good reason to think that as we continue to do this, as we provide interventions earlier, we'll see even more of this. And I'll talk about this again at the end. So we think several factors are involved in this change in outcome. First of all, the early diagnosis and the intervention. We now have a number of evidence-based interventions. There have been some changes in diagnostic practice that might account for some of this, but as I showed you, these data were really before DSM-4, so that wouldn't account for most of it. Clearly, not every child gets better. We have some children, and we can't predict who, and it frustrates the heck out of parents, because a parent of a 2 or 3 year old will say, how's he going to do, doc? And you have to say, I can't tell you. I can tell you for groups of kids. I can tell you these are the things to look for. But you will see some children at 2, 3, 4 years of age who all of a sudden get it and thump, take off like a rocket. And it gets amazing to see, but you do see it. On the other hand, you see some children in good programs who just stay there. They're like a rock. And we can't predict really who. It's possible, as now we're starting to use things like EEGs and other things to look at treatment effects, that we may get better at seeing who does and doesn't respond to treatments. It's a very interesting issue. We have more and better supports. I mentioned, unfortunately, there's issues of matching children to treatments. You have some children who might be great candidates for ABA. They're in a TEACH program, which again, a lovely program, but it's not ABA. You might have some kids who do better in a TEACH program, they're in an ABA program. So again, this issue of matching kids and treatments is very complicated. There's a very good book by Peter Doring called Autism Across America, where he talks about some of these paradoxes. The interventions for 56 to 1980 were basically unstructured treatments. We had some drug treatments, not so many. After Public Law 94-142, there's all of a sudden great interest. There was a report from the National Research Council called Educating Children with Autism that came out. We're actually just redoing this, called Revisiting Educating Children with Autism. This book from the National Research Council came out and said, basically, educating children with autism is important. We see important changes. It recommended 25 hours of treatment before kids went to preschool, before kids went to school. So it was a big game changer. It was 10 programs around the country that had at least one published study that showed that their program worked. But again, after that, there's been a really explosion of evidence-based treatments, and the programs have gotten much better as well as the evaluation of them. So we have more and more books on evaluating evidence-based treatments. There are practice guidelines out there. There's more stuff. We know that there are all kinds of approaches to teaching. There are some programs like Teach that are more eclectic. We have ABA, Applied Behavior Analysis. We have some developmental programs like Sally Rogers, Kanakassari, that are more focused on sort of fostering certain developmental areas and skills. And then finally, we have Pivotal Response, which is an interesting combination of behavioral and developmental, and then they pick certain areas that they see are pivotal for enhancing development, and they focus very much on those, but in kind of a more naturalistic, ecological way. So the gaps in intervention research, and especially for older individuals, there's almost no work. There was a paper some years ago, Joe Piven and some colleagues, that basically said there's no papers on aging and autism. And if you read that paper, you'd mastered the literature. That's no longer the case. We now have, for the first time, some work going on this. It's a very interesting area, but there's very limited data. We're generalizing a lot from our work with children and adolescents to our work with adults and older individuals. There's no data looking at very little data looking at older individuals in autism. For example, seizures, we assume there may be an increased risk for seizure. I have a client who I take care of in a group home who's in her 60s, and she had her first seizure. And I got a call from the ER up in Dartmouth, where she was at the summer place that they go to, and said she had the seizure, and we agreed she didn't need to be treated. She had only one seizure. She wasn't driving equipment, blah, blah, blah. And he said, okay, as soon as she starts to talk, I'll release her from the ER. I said, well, I've known the lady for 25 years, and she's never said a word to me, so get ready for the long haul. But it's interesting, we have no data to show what the rates of seizures are. If you look at something like Down syndrome, it's very different. There's a lot of interest in Down syndrome and aging because of leukemia, because of Alzheimer's. Again, we just don't know in autism, sadly. We clearly need better metrics. Things like looking at more neurobiological things, EEG, eye tracking things, even to you can have something like turning in response to prosody or voice. That might be much better than our current approaches. Our current approaches to screening, I'm sorry to say, are not horribly effective. There was some data from Norway that shows that the most commonly used instrument works about as well as flipping a coin. And the trouble is it overpicks up developmentally disabled, and it underpicks up the more able kids with autism. I also, just to highlight this, if you look, the gray bars are papers being published in autism, the black bars are papers on intervention in autism. Intervention studies are the hardest to do, they're the hardest to get funded, the hardest to get published. If you've ever been a reviewer, or you will be a reviewer in the future, you see an intervention study come through, people are they're gunning for it. Somebody in the review panel will say, oh, they didn't use my instrument, or they didn't use Joe's instrument. And it all goes to heck after that because people are involved and they'll find some flaw. It's like an oriental rug. It always has to have some problem with it. And that usually kills it. The feds have been most effective when they've forced people really to do a single study. And that has actually been more effective than other things. Social policy issues. I mentioned it's very interesting. We have essentially experiments going on in all 50 states looking at how autism is provided services starting in young childhood and in schools. But nobody's really considering what that is. It varies tremendously. I'll sometimes be in the position of advising people in this state to move from one town to another because they get better services. Other places I will say, move out of such and such and move across the river. Be a different state, but you get much better services. And it's a paradox, and nobody's looked at it. And I really can't say there's no good reason why. As I mentioned, there's a good book by Peter Doring called Autism America that kind of takes up this problem. It's also been, to some extent, a problem translating research into practice. As you know, anytime we take a research intervention out of the field, every single step you kind of get attrition in terms of how effective the practitioners are, how well trained they are, how faithful they are to the protocol, blah, blah, blah. But I think the other problem is that as researchers, we need to do a better job of taking what we know from research and explaining it to people and teachers in ways that they can find helpful and approachable. If you look at the World Wide Web, I checked last night, there were over 125 million hits if you type autism into Google. If you can imagine if you're a parent doing that, what you're going to be hit with, it's a lot. Even among the top 100 websites, and there are several published papers on this, about a third of them are either going to promise you a cure or ask for money. And again, it's a problem, but parents really need help in terms of finding good resources. Oh, and I mentioned the online course. This course, as you heard, this lecture is going to be online. It's gotten a very substantial viewing, which is great. We update it periodically. but having good resources like that available for free is an important thing. Let me just mention very quickly some general principles of the interaction of research with clinical work. I had, as a patient, a fairly high-functioning young man who had several interests. He came to me saying he wanted a girlfriend, and we got him 2.5 years, we got him a girlfriend, we got him going on a double date. We did a whole package of stuff with him, it was great. And he came into my office every day and sat there, didn't look at me usually, and we would talk. And about 6 months into it, I said, you know, Joe, I want you to pretend I'm a girl. And he looked at me, which was unusual. He looked at me and said, Dr. Volkmar, I can't pretend you're a girl. You got a mustache. You got white hair, for Christ's sake. And he said, why would I do that? I said, Joe, if you can do that, I will tell you what the girl is thinking. And he looked at me with these big eyes. You can do that? I said, yes. Anyway, and after every session, he was going down and writing down rules. 157, Volkmar says, don't pick your nose. Girls don't like it. And but we got him a girlfriend. We got him to start a chess club at school. He got some friends. He started to go out on he went out on a double date with one of the guys from the chess club. And they said, Joe, we got to take you to Macy's to get you some new clothes because you look like a geek. And the kid looks at me and says, Dr. Volkmar, do I look like a geek? I said, yeah, you look like a geek. And doing psychotherapy with this population is very interesting. But he said, well, how can I look different? And I said, Joe, I'm going to tell you something that's going to really freak you out. And he said, what's that? And I said, see my scissors over there? We're going to cut that top button off of your shirt. Joe came in every time, no tie, all the buttons are buttoned, right? So you'll forgive my saying, he looks like a traveling missionary. And he looks very different from his classmates. And he said, oh, I can't do that. I'll deface my shirt. My mom will kill me. And I said, Joe, I'm willing to bet you $10. Right? $10 that your mom's going to like it. The kids are going to comment that you look different. And so we did it. He came back in the next time with $10. He says, I don't know how you knew that. But things like that. But again, he's very successfully enrolled so far, knock on wood, in a college up in Boston. But the interesting reason for telling this is while I was working with him and he had my cell phone number, he also had an interest, among other things, in the interchanges on Interstate 95. You know, South Carolina exit 63 is having problems with blah, blah, blah. And subways. He was interested in subways. And I had to cancel one meeting because I had to be in Washington for working on something for the National Research Council. And it was horrible weather, and the train stopped a couple of times. I checked if the meeting was going to happen because they were predicting a blizzard in Washington, which just means it's impossible. So I get there, there's 6 inches of snow, the city's shut down. You have to pay $50 just to get into a cab. And I slip and slide to the hotel. The next morning, there's no cabs. I have to go to the subway. I'm getting on the red line at DuPont Circle, having fought my way through the snow, fought my way through all the people. It's like the Tokyo subways, pawing my way in. I get in the subway door. The door closes, I get a text from my patient, Dr. Volkmar, don't take the red line. And he was absolutely right. 10 minutes later, it stopped. And there was some debris on the track or something. But anyway, it's interesting. Every now and then, you see these funny things that happen. And lastly, quickly to end with a happy note, Jamie McCartland has joined me in teaching this class. We've done it now for over 30 years, these Yale students who have a seminar and they have lectures, but then they go out and work in the schools, Chapel Haven, Ben Haven, with people with autism spectrum disorder. And it's an unusual course for Yale, and as I mentioned, it's online. But to get into the course, because it's limited to about 20 kids, they have to write me a little essay. And the essay is where they are at Yale, why they're taking the course, et cetera, and they send it in. I have a teaching fellow, and I say to the teaching fellow, okay, this is the deal. First take the seniors, then take the juniors, then take the sophomores, then take the freshmen. But if anybody says they're a sibling, take them. And every year I'll have a couple of people who are siblings. And I said, whatever else is true, they should get something out of being a sibling. And so I always take them. And a couple of years ago now, my teaching fellow said, Dr. Volkmar, this is not quite what you said, but I want you to read the student's essay. And I want to take this because I want to be a better advocate for people with autism, because I have autism and I've never told anybody at Yale that. And so I said, okay, the kid's in. And I got to know him, and yeah, sure enough, I'm dealing with him as a professor, not as a clinician, but I can tell you, he sure had autism. But it's very interesting. We have more and more students. The last I heard, we have 5 students at Yale. At Southern, which I also work part-time now, we have over, I think, 45 students who've identified, which means probably have double that. So more and more kids are going to college. It's creating some interesting challenges. That's a whole different topic. And we're having a conference, as you heard, this fall, talking about just these transitional issues. But the good news is more and more people are doing better and better. And we have to now be able to gear up to service them. So that being said, the take-home lesson, if you met one person with autism, you've met one person with autism. And so keep that in mind. And since this is Yale, I hope as a bulldog, I haven't put you to sleep. And finally, here's some references. I'll put number 1 up just for a minute, and I'll go to number 2, and then we'll be all done, and we can stop the filming. And we have a few minutes for a question, Kasha? Whoops. Okay, all done. Thank you very much.